Okay, so today we'll understand the new global definition of ARDS, which came somewhere around 2023 and 24. So this is an updated definition of ARDS. But before going to that, we'll look into the previous two definitions also, which has held a lot in understanding of the ARDS and diagnosing the ARDS, and we'll understand why was the need of certain things to be added in the new definition, and this will help to remember the definition in a more authentic way or more easy way. So what is ARDS? So earlier it was known as adult respiratory distress syndrome, and nowadays it is known as, which later came known as acute respiratory distress syndrome, ARDS. So basically it's an intense inflammatory response triggered by a certain pulmonary and non-pulmonary causes, pulmonary like pneumonia, non-pulmonary like stroma, burn, pancreatitis. Many causes are there, and because of this intense inflammation there is a leaky capillaries, and because of the leaky pulmonary capillaries, there occurs pulmonary edema both intra-alveolar and the outside also of the alveolus, and because of this there happens to be dependent pulmonary edema develops more, so there is a basal atelectasis also and perfusion mismatch sort of things, and then on histopathological level there is a hyaline membrane development around the alveoli. So all these leads to hypoxemia to the patients. So this is the basic background. The trigger can be anything, and this is the end result sort of that process. So let's go to now with this background, let's go to the first definition, which came in 1994, which was AECC definition. Let's see. So this is the 1994 AECC definition, American European Consensus Conference definition, and this is the 2012 Bernal definition, which most of us were using, and it was very helpful. So let's see what was the difference in these two definitions, which will help us understanding the newer definition of 2024. So the onset, according to this definition, should be acute. Now acute means it should be it defined as acute, but it didn't define as whether it's week, hours, months, whatever. So in 2012 Berlin definition gave this answer. So it should be less than 7 days within the onset of predisposing clinical condition. Suppose a trigger happened, pancreatitis developed, or something has developed, or a pneumonia develops, then within 7 days this onset should be there of the ARDS. So this was the first difference. This is Berlin definition, this is AEC definition. X-ray abnormalities. So by 1994 there was only X-rays were available. So bilateral opacities on the X-ray, no characteristics were defined technically. In 12 they included CT scan also. So bilateral opacities on X-ray or CT scan not attributed to pleural effusion, atelectasis or nodules. So you cannot means on the X-ray and CT, if you can see this is pleural effusion, or if you can say this is atelectasis, or this is some nodular pattern or lobar pneumonia sort of thing, that means this is not ARDS. That means those opacities cannot be explained. Technically it is bilateral fluffy shadows, bilateral non-homogeneous pattern, patchy sort of thing on X-ray. Now how the pulmonary edema develops in the ARDS, there becomes a capillary leak, pulmonary capillary leak, and the fluid gets out into the interstitium of the lung, and then pulmonary edema develops. While in cardiogenic there is a backward hydrostatic pressure, and because of that the pulmonary edema develops. So they said that pulmonary edema should be non-cardiogenic in origin. No evidence of increased pressure in the left atrium pulmonary wedge pressure less than 18 mmHg. So how at that time in 1994 they were defining that it is a non-cardiogenic pulmonary edema. So PAC, what you get, Schwann-Gas catheter was very much used. So in that the pulmonary artery wedge pressure, if it is less than 18, that means the LA or left ventricle is fine, and this edema is because of the pulmonary leakage sort of things. Now in 2012 they removed that. So they remove because PAC is pulmonary artery catheter, or these catheters were not in much use, so they removed that, and they said that respiratory failure that cannot be attributed to heart failure or volume overload, and they added echocardiography to it. So means if there is a pulmonary edema, you cannot say that it is because of the cardiac condition per se, or cardiac failure or fluid overload. There has to be something else. Now these were the definition. Oxygenation, so they defined that if it is less PaO2 upon FiO2 ratio, if it is less than 300, it was acute lung injury. And if the PaO2 FiO2 ratio is less than 200 or equal to 200, then they will call as ARDS. While here they defined as mild, moderate, severe. If it is less than 300, it was ARDS. And so PaO2 of FiO2 ratio, if it is less than 300, it was ARDS. So between 201 to 300, it was mild. If it was between 200 to 101, it was moderate. If it is less than 100, severe ARDS. That was fine, clear. And remember, for PaO2 FiO2 ratio, with that, they need at least greater than 5 mm of PEEP. So patient, suppose the patient is on ventilator, then a patient should have at least 5 of PEEP. In mild category, if the patient is on NIV, then EPAP, or if the patient is on CPAP, then it should be of minimum of 5 or equal to 5 centimeter of water. Then only PaO2 FiO2 ratio was calculated. Predisposing condition in 1994 definition was not specified. They didn't define it. They just said it is an acute condition there in which there is a bilateral opacities, and it is a non-cardiogenic pulmonary edema, and a PaO2 FiO2 ratio false. While Berlin definition shows that predisposing conditions, they said that there should be predisposing condition. It should be within 7 days of onset. On X-ray CT, it should not have pleural effusion or atelectasis or nodules. You cannot attribute those shadows to them. Respiratory failure cannot be explained by heart failure or volume overload, and mild, moderate, severe category was defined. So you can use echocardiography or pro-BNP or anti-BNP to rule out the cardiogenic pulmonary edema. So it was a very good definition, and it was being used till date also. Many people still use it. It was fine. So what was the logic behind all this definition? Why 7 days? So why between 7 days they said? Because in the rationale was that observational data suggested that ARDS will develop within 72 hours in majority of the patients, and almost all patients develop ARDS within 1 week. So 1 week was defined as that point, and rest of the findings I had explained you: mild, moderate, severe category, and non-cardiogenic pulmonary edema. Okay, so this was the Berlin definition. Again, just for revision, so this was the 2012 definition, which many of you and me also know that we were using it. We have used it in the COVID era also. The timing within 1 week of onset of clinical insight of or new or worsening respiratory symptoms. Chest imaging, CT and X-ray chest, which is bilateral opacity. See, similarly here bilateral opacity is mentioned. It's not unilateral. It should be bilateral, not fully explained by effusion, lobar, lung collapse or nodules. Same thing. Origin of edema, respiratory failure, not fully explained by cardiac failure or fluid overload. Objective assessment you can do by cardiography or anti-proBNP also. And the oxygenation was, if it is less than 300, then it's ARDS. Between 200 to 300 PO2 FiO2 ratio, mild ARDS. Between 100 to 200 is moderate ARDS, and less than 100 is mild ARDS. PEEP or CPAP should be at least 5 mm Hg. Now, so this was doing fine. Then why was the need for new definition? So one thing was that there was bilateral shadows and you were not able to explain these things clinically. You need some other things also, something more which can say that this is ARDS, more specific. Then the use of HFNO also come into play in COVID. Many patients are being treated of high flow nasal oxygen, HFNO, these type of instruments, they came into play. Then the role of ultrasound chest also increased. USG chest was introduced as a modality which proved very helpful at the bedside, but it was operator dependent, but at bedside. You see these B lines are there, which are abnormal lines. So, and also one more thing was in COVID we have seen that there was a huge amount of patients and the resources were limited. Not every center was having NIV, HFNO or ventilator. or ABG machines. They were getting treated at places in small nursing homes where just a ICU facility with oxygenation was available or SpO2 probe was available. So there has to be something which could help to define ARDS, because if they don't have an ABG, how they will say that there is a PO2? So 4 things happened in this. This is the new definition of ARDS. This is the new global definition of ARDS, and I'll explain you. So 4 things they introduced in this ARDS. 1, along with CT, X-ray chest and CT, they introduced USG chest as one modality for the chest imaging. Secondly, along with NIV or BiPAP, which you call it, or intubation, they introduced HFNC. HFNO, high flow nasal oxygenation was introduced. If the patient is on that, how will you define? Thirdly, because in centers where the ABG machines were not available, SpO2 FiO2 ratio was introduced. Earlier it was PO2 FiO2 ratio, it was continued, but they correlated and then brought up a new ratio, which is SpO2 FiO2 ratio. And fourthly was the resource limited settings, like where they don't have a NIV or ventilator or HFNC, still or ABG machine, still we need to diagnose a ARDS. So this is the definition. It's very simple. We'll see that. So first is the conceptual model. I have explained you in the starting, but just for more authentic or revision, let's see that. So ARDS is an acute, diffuse, bilateral, inflammatory lung injury precipitated by a predisposing risk factor such as pneumonia, means lung injury, or non-pulmonary infection, trauma, transfusion, burn, aspiration, shock, anything. The resulting injury leads to increased pulmonary vasculature and epithelial permeability. So the pulmonary edema will develop, the lung edema will develop, and there is a gravity dependent atelectasis, all which contribute to loss of aerated lung tissue. This is the mechanism. And the clinical hallmark is sort of refractory arterial hypoxemia and diffuse radiological opacities with increased shunting, increased alveolar dead space and decreased lung collapse. Lungs becomes very stiff. If you go to the histopathological level, they have an intraalveolar edema, inflammation, hyaline membrane formation, which because of the hyaline membrane formation, the oxygenation becomes very difficult, and the CO2 expiration also becomes difficult, and there is a alveolar hemorrhage. So this is the mechanism by which the ARDS develop. Now let's see the our definition per se. So criteria that applies to all ARDS. In every patient, these 3 things should be there. 4 things actually: risk factor, origin, edema. So 4 things should be there in every patient, whether it's non-intubated, whether it's intubated, or whether it's a resource limited setting. So what are the 3 things? First is the risk factor should be present. Secondly, the origin or edema should not be purely cardiogenic. Understanding now the definition how is changing. Earlier it was that the edema should not be explained by a cardiogenic or fluid overload, but now we'll see. So risk factor, it is precipitated by an acute predisposing risk factor such as pneumonia, non-pulmonary infection, transfusion, aspiration, shock. Means you need to have certain thing. You need to have certain thing to explain why this patient has developed ARDS. So you need to have at least one risk factor present. There are a lot of causes of ARDS. You can go and read. Origin of edema. So pulmonary edema, we are talking about non-cardiogenic pulmonary edema. ARDS is a non-cardiogenic pulmonary edema. So pulmonary edema is there in the patient, but it is not exclusively or primarily attributable to cardiogenic pulmonary edema fluid overload. Means patient can have pulmonary edema, but patient can have cardiogenic pulmonary edema, patient can have fluid overload, but it is not exclusive, or it is primarily a cardiogenic pulmonary edema, or it's not an exclusive cardiogenic pulmonary edema or fluid overload. There has to be something else going on in the patient which explains this patient is also having non-cardiogenic pulmonary edema or ARDS. So means now cardiogenic pulmonary edema or non-cardiogenic pulmonary edema can both exist. Fluid overload and ARDS can coexist. Means suppose the patient is having fluid overload, but you see now, no. There has to be something in this. This is not purely a fluid overload. Okay, the LV is 30%. Patient may have some component of pulmonary edema, but this is not totally pulmonary edema. There has to be something, this sort of condition. So, pulmonary edema is not exclusively or primarily attributable to cardiogenic pulmonary edema or fluid overload, and hypoxemia and gas exchange abnormalities are not primarily attributable to atelectasis. Suppose a patient is lying down for a longer period of time, or there is a trauma, or there is a basal atelectasis. So we cannot say that this hypoxemia is due to atelectasis. There has to be something. So that's the this line is very important. However, ARDS can be diagnosed in the presence of these conditions if a predisposing risk factor of ARDS is also present. So now ARDS can be present along with pathogenic pulmonary edema or fluid overload, where you can say that no, this condition is not explainable by cardiogenic pulmonary edema or fluid overload. There has to be something else other than these factors, and we have a risk factor present for that. So this is the first thing, that there has to be risk factor, and origin of edema can be can coexist with cardiogenic or fluid overload. So there has to be non-cardiogenic pulmonary edema due to a certain risk factor. Timing remains unchanged. It is still 1 week. Acute onset of worsening hypoxic respiratory failure within 1 week of the estimated onset of predisposing risk factor or new or worsening respiratory symptom. So whether this is a new symptom has developed or the patient has worsened the respiratory symptom, but the duration is within 1 week. Now chest imaging. What is added to chest imaging? Earlier there was X-ray in 1994, then added CT, and now we had USG chest, in which there are presence of B lines are there. So bilateral opacities on chest radiograph or CT scan, or bilateral B lines or consolidation or ultrasound not fully explained by effusion atelectasis nodules. That's explainable. You cannot explain that just by effusion. There has to be bilateral shadows, fluffy shadows, which are peculiar of ARDS, and they cannot be attributed to effusion atelectasis masses. So USG ultrasound. So now the benefit of USG ultrasound was, in COVID you have seen many patients are there in the ICU. It's not possible. They are so unstable at times. It's not possible to take them every time to the downstairs to CT scan or move to the CT scan modality. So USG, bedside USG can be done, and we can see the B lines. So this has helped. So now we have chest radiograph, we have CT, and we have ultrasound. So that's the first change you are seeing. So risk factor, origin of edema, we have explained. Timing 1 week, we have seen chest imaging, CT, X-ray or ultrasound. Now this should be present in every patient in whom you are diagnosing ARDS. Now the criteria that's apply specific to ARDS categories: mild, moderate, severe. So non-intubated patients, they have divided into three: non-intubated, intubated, and resource limited setting. Non-intubated ARDS means the patient is or can be on either NIV, BiPAP mask, or can be on HFNC or HFNO, the patient on these oxygen. So, and the other thing which is included in this category, along with PaO2 FiO2, you can now use SpO2 FiO2 ratio. But remember, for taking SpO2 FiO2 ratio, you need to make sure that the saturation or SpO2 is less than 97%. If it is more than 97%, 98, 99, then this is not ARDS. The patient saturation has fallen below 97%, and then we are taking the SpO2 FiO2 ratio. So oxygenation, if previously also we saw that if the PaO2 FiO2 ratio is less than 300, it comes under the category of ARDS. So if the patient is on NIV or CPAP mask with at least 5 centimeter of STO of PEEP or EPAP, then we say it's ARDS. Now if the patient is on NIV and with 5 centimeter of EPAP or CPAP, you don't have an ABG machine, then if the SpO2 FiO2 ratio is less than 315, you see here PaO2 FiO2 ratio is less than 300, but SpO2 FiO2 315. You see oxygen dissociation curve is there for PaO2 and SpO2 category. That's why it's not correlating 300. So for first thing is SpO2 FiO2 ratio less than 315 or PaO2 FiO2 less than 300 if the patient is on NIV or CPAP with at least 5 centimeter of EPAP or PEEP. Now, if the patient is on HFNC, then the flow of the HFNC should be more than 30 liter per minute. Means you are requiring that amount of oxygenation, that amount of flow. Then only you will say that this is patient is ARDS. So, if the patient is on HFNC, if the flow is more than 30 liters per minute, and either FiO2, either PO2 FiO2 ratio is less than 300, or SpO2 FiO2 ratio is less than 315, we call it ARDS. So, all these criteria present. And in non-intubated patient, either on a HFNC flow more than 30 liter, or NIV PEEP more than of 5, or CPAP PEEP pressure more than of 5, if the PO2 FiO2 ratio is less than 300, or SpO2 FiO2 less than ratio less than 315, with the condition that saturation should be less than 97%. So we call it ARDS. There is no mild, moderate, severe in this category. Now, in intubated patient, the criteria remain the same for PO2 FiO2. If the PO2 FiO2 is between 300 to 200, it's mild ARDS. If the PO2 FiO2 ratio is between 200 to 101 or 100, it is moderate ARDS. If the PO2 FiO2 ratio is less than 100 on intubated patients, then it is severe ARDS. But now, if we don't have ABG machine and we are relying on SpO2 FiO2 ratio, so the saturation should be less than 97 in all the categories. If SpO2 FiO2 ratio is less than 315, where we call as ARDS, we have seen here less than 355. So if it is between 315 to 235, it is mild ARDS. If the SpO2 FiO2 ratio is less than 235 and more than 148, it is called as moderate ARDS. And if the SpO2 FiO2 ratio is less than 148, then it is called severe ARDS. So again, if the SpO2 FiO2 ratio less than 315, we'll put it in the ARDS category. So if it is between 315 and 235, mild ARDS. If the SpO2 FiO2 ratio is less than 235 and more than 144, it is moderate ARDS. And if it is less than 148, we will call as severe ARDS. So this is for intubated patient. Now this is very importantly, they have added modified definition of resource limited setting. Suppose the patient is in a small nursing home where no ABG machine is available, no NIV is available, no ventilator is available, invasive one, no HFNC is available. So how to do? So for them, all these three things should be present. There should be risk factor present. There should be origin of edema, non-cardiogenic pulmonary edema, timing within 1 week, or any imaging you on simple X-ray you feel that it's ARDS. Then, if the nothing, no pressure, no flow, no PEEP, no EPAP, no CPAP. Only thing, if your SpO2 is less than 97% and SpO2 or FiO2 ratio is less than 315, the patient can be labeled as ARDS. So that's very important thing in it. You see, modified oxygenation criteria. This is the modified definition in resource limited settings. Modified oxygenation criteria can be applied in the setting in which arterial blood gas and or HFNC, NIV and mechanical ventilation are not routinely available. So this is very good thing which is being added in this. So this is the definition, new global definition of ARDS. Very simple. There has to be risk factor present. The origin of edema should be non-cardiogenic pulmonary edema. It can be exist along with pulmonary edema or fluid overload, but you cannot explain the condition totally because of them. The timing should be within 1 week. You can diagnose them on the basis of X-ray, CT or USG ultrasound. The B line should be present. B lines like this. These are the abnormal B lines. There are 3 lines. There are more 5 lines on the USG. Then if the patient is on non-intubated, then either PO2 FiO2 ratio less than 300 or SpO2 FiO2 ratio less than 315, provided as saturation is less than 97%. If the patient is on HFNC, the flow should be more than 30 liter per minute. If the patient is on NIV or CPAP, either EPAP or PEEP should be more than 5. If the patient is intubated, again same, less than 300 PO2 FiO2 ratio, ARDS, between 200 to 300 mild ARDS, PO2 FiO2 ratio, between 100 to 200 moderate ARDS, less than 100, severe ARDS. Now if the ABG machines is not available and saturation is less than 97%, SpO2 to FiO2 ratio. If it is less than 315, ARDS. If it is between 235 to 315, mild ARDS. If it is between 148 to 235, moderate ARDS. If it is less than 148, severe ARDS. Then in resource limited settings, all all these risk factors and timing and imaging present supporting, and if the saturation is less than 97% and if the SpO2 to FiO2 ratio is less than 315, you will say that this is ARDS. So it's a very easy and very beautiful definition which can be used on day-to-day basis. Now you can go Google it and it is available everywhere. I have taken this one from uptodate.com. It's wonderfully given. It is available freely on the internet. Go and read about it and discuss with your friends, colleagues, staff, explain them. They will thank you, and thank you for listening. We'll see in the some next video soon. Thank you.